recording. I think we might be live. Sammy Ainsworth's joined again. So welcome everyone to the first webinar for today for Word Day 2022. It's been a very exciting day today. There's been a lot of activities all around the world across all 5 continents and all time zones, I think, probably. So your hosts for tonight are myself. So I'm Eve Smith. I'm a paediatric rheumatologist in Liverpool in the UK. I'll hand over to Sammy to introduce herself.
Hello, my name's Sammy Ainsworth. I'm a mum of a daughter with lupus who was diagnosed when she was 14. I also work alongside Eve in the rheumatology department of Alderhay Children's Hospital in the research department, and I'm also a trustee of Lupus UK. It's really great to be here tonight with you all.
Thanks, Sammy. Richard, do you want to introduce yourself?
Yeah, thank you. Yes, as Sammy said, it's great to be here this evening to join you. My name is Richard Beasley. I'm the founder and I run a charity in the UK called Juvenile Arthritis Research. And my wife, who you'll hear from later on, was diagnosed with juvenile arthritis when she was a child, and our daughter has JIA as well.
So the theme for today's webinar is very much linked in with the main aims of Word Day to try and improve awareness of rheumatic disease and try and improve diagnosis of patients. And we've got a really exciting panel lined up. We're not going to use time with everyone introducing themselves. They're all going to put in the chat their introductions. We're going to have some short talks from Liz Ang, who's a consultant paediatric rheumatologist in Singapore, and then from Mr. Yassin Al-Jaferi, who's the father of a patient with JIA in Saudi Arabia. And then we'll move on to the Q&A sessions. And we have got some questions from you, thanks to those who sent questions through in advance. But if you could put some questions in the chat during the talks or at any point, then that would be great. And then we'll crack on with the question and answer session. We've got an hour for this session. Thank you very much.
Can we just confirm that we'd like any questions actually put into the Q&A part of the chat, not the usual part of the chat. There's a Q&A section which you'll find at the bottom of your screen.
Thanks. Coralie, do you want to play Lizzie's pre-recorded video, please?
Good evening from Singapore. My name is Elizabeth Ang and I am a pediatric rheumatologist in Singapore. It's really my privilege and pleasure to be able to spend the next 10 minutes with you talking about when to suspect a pediatric rheumatic disease and to refer. Let's begin. I wanted to start by just mentioning some of the diseases that we look after. Perhaps the most well-known would be juvenile idiopathic arthritis, also known as JIA, followed by systemic lupus erythematosus, SLE, and juvenile dermatomyositis. But that's not all. We also look after children with systemic vasculitides like Takayasu arteritis and ANCA-associated vasculitis, periodic fever syndromes, autoinflammatory syndromes, musculoskeletal pain syndromes, and the list really goes on. The outline of my talk tonight includes the following: when to refer, secondly, common misconceptions, and finally, why early and right diagnosis matters. Let's begin with a list of conditions or symptoms that should prompt consideration for referral to a pediatric rheumatologist, namely the limping child, a child with joint and or bone pain, a child with prolonged periodic or recurrent fevers, a child who has multi-system disease, and a child who has unexplained rashes with or without fever. In such cases, it is really important to recognize certain patterns of presentation. Let me begin with the first condition or the first symptom complex, the limping child. This is not an uncommon presentation, but it is important to note that not all limping children have JIA. There are other serious underlying pathologies to consider, and I've listed them below. Pattern recognition refers to how the symptoms associated with the limp can point to a specific diagnosis. For example, the child with a hot, swollen joint who has marked fever and irritability most likely has a serious bone and/or joint infection like septic arthritis, whereas the child who has associated bruising, pallor, night sweats may have a malignancy like leukemia. In the child who's otherwise well, who has had an upper respiratory or gastrointestinal infection 1 to 2 weeks prior, the diagnosis may just be a reactive arthritis. On the other hand, a toddler who is limping and prefers sitting with his or her spine in an extended position may have infectious discitis. When the limp is associated with stiffness that is worse after a period of immobility or after a night's sleep and in the early morning, then inflammatory causes must be sought. Pain that is severe enough to wake the child at night is a red flag for serious conditions like malignancy, first and foremost. Pain, on the other hand, that is worsened by exertion and relieved by rest is often mechanical in nature. Finally, pain that has a bizarre pattern often raises the concern for psychosocial stressors and child abuse. In this slide, I list the red flags that raise concern about serious causes like infection, malignancy, and non-accidental injury. The other pattern to think about would be the child who presents with multi-system or systemic diseases. By systemic, I mean the child who presents with an acute or subacute history of constitutional symptoms like fever, fatigue, and weight loss, or the child in whom history, physical examination, and lab investigations reveal multi-system involvement. For example, cytopenias, skin and joint problems, nephritis, hepatitis, neuropsychiatric, and pulmonary problems. Examples of rheumatic conditions that can present in this way have been listed in this circle on the center and upper part of the slide. I wanted to highlight some of the rashes that should make one think about referral to a rheumatologist. On the top left-hand corner, you see the typical butterfly rash of lupus. This refers to marked malar erythema that often crosses and involves the nasal bridge and or nasolabial folds. However, this sort of rash may be seen in dermatomyositis as well. When you see a facial rash that has a preference for the periorbital region, which may appear purplish or heliotrope, then dermatomyositis must be considered as well. Sometimes the rashes are not so obvious and just give the child a rosy-cheeked appearance. Then look a little harder. Sometimes vasculitis can appear in the gums, making the gums look extra red and slightly swollen. Or the clues may be found in the hands, as in this picture, which is fairly typical for dermatomyositis, namely marked but patchy erythema across the knuckles and with a predilection for extensor surfaces. What are other clues to rashes that are vasculitic in nature? Well, vasculitic rashes tend to be non-blanching, palpable, and sometimes painful. They're often photosensitive or may be distributed in areas exposed to the sun. For many of you experienced general pediatricians or general practitioners out there, sometimes if the rash just looks weird and different from the usual viral exanthems, then think about whether these rashes could be a sign of rheumatic conditions. So we've covered very briefly the symptom complexes that should prompt referral to a rheumatologist. Because JIA is probably the most common condition that a pediatric rheumatologist sees, I want to cover some common misconceptions in childhood arthritis. Misconception 1. That child is too young to have arthritis. It's just growing pains. This is not true. Arthritis can start in infancy. There is a subtype of JIA called oligoarthritis that has one peak incidence around the age of 2 years old. Misconception 2. This child is not in pain, it cannot be arthritis. Well, the thing is, children don't often complain of pain, especially children who are neuroatypical. For example, the child with trisomy 21 or the child with an autistic spectrum disorder. On the other hand, the child may not seem to be in pain because children compensate so well by using or bending that joint less. On the other hand, they may be in pain, but it's just that we as their doctors have to get better at joint examination in children. Misconception 3. The blood tests and x-rays are normal. It cannot be arthritis. Well, please remember arthritis is diagnosed on history and physical exam primarily. Sometimes for deep joints like the hip and sacroiliac joint, ultrasound or MRI may be helpful, but the history and physical exam is the basis on which the diagnosis of arthritis should be made. Blood tests and x-rays are useful for excluding other conditions, but may be completely normal in a child with JIA. Here's another misconception. Arthritis is just about the joints. Nope. Sometimes arthritis can present with enthesitis, dactylitis, or tarsitis. Enthesitis refers to inflammation at where a muscle inserts to a bone. For example, the Achilles tendon can get inflamed, and this can cause a very diffuse and not always obvious swelling at the heel. Dactylitis refers to a tenosynovitis around the digits, causing a diffuse swelling, making the digit look rather like a sausage. Dactylitis is also known as a sausage digit and may be missed if not looked for carefully. Tarsitis refers to inflammation around the tarsal bones, and because sometimes this inflammation can be so diffuse and warm, it can look like a cellulitis. And of course, juvenile idiopathic arthritis is associated with uveitis. One more misconception. A short course of oral steroids should be fine, then let's see what happens. Note that steroids can be harmful if the cause of the bone and joint pain is infection or malignancy, in particular leukemia. So when in doubt, refer to a rheumatologist. Here is a summary of the common misconceptions in childhood arthritis. When in doubt, refer early to a pediatric rheumatologist. Finally, why does early and right diagnosis of childhood rheumatic disease matter so much? Well, firstly, rheumatic conditions in childhood are a lot more common than you think. Late diagnosis can cause permanent damage, not just for the joints, but also for the eyes, in the child's growth, in the child's kidney function, in the child's mental well-being and ability to function as an adult. Late diagnosis can cause death, and this would be the case in some patients with SLE or macrophage activation syndrome. And of course, on the bright side, right diagnosis can allow children and young people with rheumatic disease to live really well. You can make a difference. On this last slide, I leave you with some resources that may be helpful for children and families with rheumatic conditions, as well as healthcare providers who care for such children. Thank you very much, and I wish you a wonderful discussion together. Good evening.
I'm sure you'll all agree that was a really fantastic talk from Liz, a whistle-stop tour around pattern recognition, red flags, when to refer. She challenged a lot of important misconceptions and really emphasised why it's so important to get the diagnosis right in children with paediatric rheumatic diseases. So now we just like to pass over to Mr. Yasir Al-Jafrezi, who's a father of a patient with JIA from Saudi Arabia.
Yeah, thank you so much, and thank you for having me. Good evening from Saudi Arabia, and thank you for having me. Before I start my speech, I would like to start with a quote from Prophet Muhammad, peace be upon him, which he said, "Knows that what has reached you was never meant to miss you, and what has missed you was never meant to reach you." Ladies and gentlemen, parents of the warrior kids, or as I would like to call them, the kids of hope, the arthritis community, audience around the globe, allow me to introduce myself. I am Yasir Al-Jifri, and I'm happy to be sharing my son's story in the hope it will benefit other parents and the arthritis community. In October 2020, my son was diagnosed with arthritis. As a scholar in the area of risk management often says, risk equals opportunity. For us, the risk presented by the COVID-19 pandemic, which resulted in the complete lockdown of the country and curfew was an opportunity for us to stay at home and observe by chance the abnormality on my son's knee. At first, we thought the inflammations in my son's right knee had been caused by mild injury from either playing, falling on the ground, or even fighting over toys with other kids. As we all know, as a parent, protecting our child from injury is quite challenging. However, after a week or so, the inflammation has not gone away and had maybe getting worsened. We also start to notice a reduction in his appetite and his sleep was interrupted. With the easing of the COVID-19 restrictions, we took our son to pediatric orthopedics because we thought the symptoms were related to some minor injury, but not an autoimmune disorder. We consulted 2 doctors who, after conducting x-rays and primary blood work, both recommended that we consulted a pediatric rheumatologist. We don't have any relative or friend who have arthritis or kids with arthritis. The only experience we had with this disease was when my wife was diagnosed with rheumatoid arthritis precisely 1 year after giving birth of my son. Her experience of arthritis was very painful, and it was a real struggle for her. It impacted her energy, her emotions, and her movement. So we were really worried that our son was in severe pain and discomfort, and that feeling was really devastating. So fearing the unknown and very worried about our son's health and futures, we began our search for pediatric rheumatologist physicians. We were offered treatment plan, which include MRI, which required our son to be under general anesthesia, joint inspirational operations to remove the fluid from around the joints, and medications, which include methotrexate and Humira, which we consider a high-risk medications. Honestly, at that stage, it was too much for us to comprehend and accept. And our heart was really breaking just thinking about needing to put our 3-year-old son through all of that suffering. However, after my son's case was accepted by government hospital, the actual treatment plan was finally structured and implemented. Our physician started his treatment plan by first treating our anxiety and shifting us from the state of being fearful to being willing to take action to support our son. Indeed, this reminds me of a quote by William Clement Stone when he said, "Thinking will not overcome fear, but action will." We then started with an anti-inflammatory medication called Sabofin. My wife and I were worried about the side effect of this medication as it's well known to cause kidney failures and gastrointestinal problems. The physicians was more lean toward medication more than any operations for the fact that of multiple joint is being impacted. We then started by taking methotrexate and Humira. My son experienced the following condition after receiving the first dose of methotrexate: nausea, lack of appetite, and a little bit of dizziness. Although, ladies and gentlemen, our experience of our son arthritis is relatively new, and there are many things for us to experience and learn. We would like to share some of the key learnings so far. 1, perform an active learning to your kids, as sometimes they direct us to the real problems. 2, message can be delivered to patients and parents in one of 2 ways. One way will emotionally stress the parent and prevent them from acting. The other way will motivate the parents and make them part of the decision-making process. Last but not the least, which I learned from my son physician, the art of managing expectations. I will never forget the day we were discussing my son's situations, hoping to find an answer about when my son will be 100% cured from the disease. And the physician stopped me and asked me a very simple question. What is the objective you're trying to achieve from the treatment? Indeed, that was a wake-up moment for us, to be realistic and to understand where we are going with our plan. Ladies and gentlemen, I would like to conclude with Michael Atulcher's quote when he said, "The bad news is time fly. The good news is that you are the pilot." Thank you so much for listening, and sorry for taking a long time.
Thank you so much for your very inspirational talk, Yassir. It's so brilliant of you to share your story. Some really fantastic highlights of the difficulties of how to get a diagnosis, some of the fears that you had at the beginning on receiving the diagnosis and thinking about this treatment, but ultimately your talk was very inspirational, showed us how you dealt with those fears, took action, and the key learning points that you've already got in such a short time. So we'll open the discussion up now for so if anybody could put some questions into the Q&A box, we'll make a start on some questions that we're submitting in advance, but it'd be really great to hear some questions from the audience, really on anything around diagnosis or related to paediatric rheumatic diseases. So I'll just make a start with a question then. So this is one that came in advance from so it just says, what options are there for families to access treatment for rheumatic diseases in countries where the costs are prohibitive? For many, there's no healthcare option. Is there anything a family with a child with GIA could do to help access to medication? Angela, I don't know if you would like to start with that question, then other panel members can chip in.
Yeah, so thank you, Eve, for the question, and to the organizers of this session, and to really appreciate each and every participant who has logged on. That's a really pertinent question, Eve, and it's one thing I grapple with every day in my practice, because I get patients who come to me from Somalia, Ethiopia, Rwanda, Burundi, and I think what Mr. Yasser, I hope I got the name right, mentioned, I think is really key. This is where now you have to partner the family and try and understand from their perspective what is affordable, feasible, acceptable, and sustainable for them in their context, right? We have a mandate to educate them with what we, from our scientific knowledge, what we feel is the best solution for their child. But while honoring that medical ethical pillar of autonomy, the final decision does lie with them. And so that concept of shared decision making is very key. In my home country, Kenya, we are fortunate because we have the full spectrum of non-steroidal anti-inflammatory medications. We have got methotrexate, MMF, hydroxychloroquine, the synthetic DMARDs, and quite a bit of the biological DMARDs. But still, despite that, Eve, what I find is the greatest challenge is the acceptance to use those medications. So though cost is a huge barrier, but for me, what I'm finding is the greatest barrier is lack of acceptance of the diagnosis and the treatment options available. I don't know if I've answered your question.
Oh, that was great. Thanks, Angela. Has anyone else got anything they would like to pitch in there in response to that question? Yeah, Helen.
Yeah, if I may just add, the WHO Essential Medicines List is important for many countries in terms of informing their formularies. And I think work needs to be done to increase the list of medicines on that list for children's rheumatic diseases. At the moment, the list is not as comprehensive as we'd like it to be. And certainly the Paediatric Global MSK Task Force is working to try and expand that list. And that certainly is a step towards making some of these medications more available. And it may actually also have some leverage in terms of prices, depending on how different countries negotiate access to medicine. So WHO is certainly very supportive of us trying to raise the profile of what drugs we regard as being essential for paediatric rheumatology practice. And that might be a great step forwards towards making them increasingly available. So watch this space.
Thanks, Helen.
I think we've got another question now. Some questions have started appearing in the chat, which is fabulous. So keep them coming and we'll answer as many as we can. So this question is probably aimed more at the clinicians on the panel, but then parents and some patients might have experience of this. And the question is from David Priestley. And the question is there anything that can help with nausea caused by methotrexate? So I'm not sure who would like to answer that. Who would like to answer that first? Tade, would you maybe like to start?
Sure, thank you. Hello, everybody. It's a good question. We are often our parents also ask this question. So I would say that it's one of the most common side effects of methotrexate, the nausea, and it's very bothersome, could be very bothersome for the child and also parents. So what we see is that each child is different, so they can have different reaction. Usually we advise that the methotrexate is taken on the day when they do not go to school, so that they would not have problems at school. So this is usually Saturday. And sometimes it is helpful that they take methotrexate before breakfast, fasting. So as I mentioned, it's individual. Some of our parents mentioned that they experienced less side effects with nausea if their child take methotrexate in the evening on Friday, so that they kind of sleep over this nausea effect. So I would say that you have to find what is the best fit for your child. Thank you.
Thank you, Tede. I'm wondering whether, does anybody else have anything they would like to add?
Can I add one comment?
Yes, wonderful.
I agree entirely with my colleague comment. But as you know, methotrexate can be given as oral or subcutaneous injection. We know subcutaneous injection maybe has less side effect in terms of nausea and other side effect, but of course the injection by itself is not something liked by the kids. I also found it in my experience, if we can give the methotrexate, if it's oral, we can give it at bedtime. So probably after, I mean, as my colleague said, maybe a few hours after the meal, before the bedtime or with bedtime, so it will be easy. But usually we recommend, as my colleague said, folic acid. It will minimize the side effect as well. It can be given on daily basis as 1 milligram, or it can be given 5 milligram every week.
Thank you very much. So we've got a couple of raised hands from the panel. So I think we'll go to Aileen first, please, and then we'll move on to Rebecca, if you want to just come in with what you want to say about it.
Hi, I was going to say, I was on methotrexate for quite a while, and I was on the oral version, and something that was given to me was, I think it was called ondansetron, so it's these little film tabs that you put on your tongue. But I remember them tasting absolutely awful. So something I always say is, obviously when you've got medication, if kids are having like really a lot of side effects, to be careful to not just keep medicating the side effects, maybe look for other avenues. For me personally, I didn't get on with methotrexate at all, but some of my friends had really promising results from it. So it's all like the two previous speakers before me said, it's always a case of what works for the individual child. It's not a across the board decision, I think.
Thank you so much. That's really helpful. So
hi, I was just going to echo really what Aileen said there. It's very much not a one size fits all. And with my daughter, she was fine to start with when she started on methotrexate, no sickness, no side effects. And then that actually built over time, and it became more of an anxiety thing. And it was the anxiety that was causing the sickness. So we've tried to find ways of addressing that by kind of supporting her mental health really, and helping her find ways to kind of de-stress and relax and not to kind of panic about it. And that's been really helpful. And I think this kind of concept of really finding something that suits you and your child is vitally important. So we did it a little bit through trial and error. We were finding Friday night didn't suit us. That was the day that was recommended, but she would go to a drama class on Saturday mornings, then we'd drive there, and then she would get travel sickness. So we kind of realised that whenever we were driving somewhere the next day, she would have travel sickness. So we worked out a day that worked out better for us, where there was no travel involved. Afterwards, the ondansetron that we are now taking, the first time round did not work at all. She hated the taste, and taking the anti-sickness medicine would actually make her sick. So we scrapped that, found other ways around it. This time around, she's just restarted on methotrexate again. I get a pile of sweets and chocolate ready give her the ondansetron. I haven't told her it's the same medication that she had before, and this time it's gone down a lot better, and it has helped with the sickness. So that's just what we've been doing. That seems to have worked a lot better this time around. What we've learned from our experiences.
Oh, thank you, Rebecca. Yeah, that sounds like a really good plan, what you've done. Chocolate and sweeties will always help. Thank you. Richard, have you got a question now?
Yeah, we've had a message in from Dr. Yulia. Dr. Yulia is a paediatric rheumatologist in Ukraine. So thank you for joining us this evening with everything you're going through. Yulia says, let's arrange inspiring lectures for Ukrainian doctors after the war. And I think that's absolutely a fantastic idea to continue building and experience and skills across the community. And she says, thank you particularly to parents because you're as a patients, because your talks are inspiring, and I think we will again echo that, and it helps make the doctors move forward, helps us to learn together. And then we have a question, again, this is aimed at the clinicians. Is there a role for JAK inhibitors in children, or are there too many concerns over adverse effects? And I will ask Tade, would you like to answer that one?
Yes, thank you. There is definitely a role for JAK inhibitors and also some new medications that will come. As we already discussed, there is no one-size-fits-all. Hopefully, we already have, but hopefully in the future, we will have even more simple tests to somehow evaluate the pathogenesis of different subtypes of juvenile idiopathic arthritis. And we already have some more complicated tests to see if there is JAK-STAT activation. This is a pathway that is inhibited by JAK inhibitors. And in certain patients with juvenile idiopathic arthritis, definitely this pathway is overactivated. And for this subgroup of juvenile idiopathic patients, this type of drugs would be kind of a perfect target therapy. At the moment, we do not have, let's say, point of care tests that would give us this stratification of our patients with juvenile idiopathic arthritis. So we already use JAK inhibitors in patients who are refractory to some biologic treatments. But at least at our center, we did not start using JAK inhibitors up to now before biologics. This will probably change very soon, and we expect that JAK inhibitors will be parallel with biologics. But as I said, we would like to have some more simple tests to stratify, subclassify different juvenile idiopathic arthritis subgroups that would fit to this type of treatment.
Thank you. Angela, you would like to come in there as well?
Yeah, I just wanted to add on to what my colleague, Dr. Tajid, has discussed. In my setting, getting the children to accept the injectable biologics is not very favorable. So like for those who are have the polyarthritis, particularly RF positive, with the possibility of tofacitinib, for example, in my setting, they seem to prefer that, and I've had a few who have done well with that. Of course, I haven't had a chance to follow them for years and years to really find out what the long-term impact would be, but I think the JAK inhibitors for particular types of arthritis will be, in children, is quite revolutionary. Thank you.
Thanks, Angela. So just moving back to the Q&A, so there's a comment here from Vicky Sanan, who's from Arthritis Foundation South Africa. So her granddaughter showed symptoms of arthritis, so limp at age 2 and 5 months. She's now 8 years in a medicated remission and happily competes with her peers in all spheres. However, our observation here is that her second symptom, which we've only realised once she had been diagnosed, is that of classical early morning stiffness. So it sounds like she's still having some problems with our early morning stiffness, potentially, despite having improved in other ways. I'm not quite sure who to direct that question to. Laura or Helen, would you like to make a comment about morning stiffness?
Sure, I can start with it. And thanks so much for putting that comment in. And I couldn't quite tell from the question if it was something that they only realized looking back, like it was there initially, and you know, the limp kind of caught their eye, but then after learning more, they realized that there had been morning stiffness, like it, you know, it took a long time to get out of bed, was a lot slower, you know, took a lot longer to get ready. These are very common stories that we hear from our families. And one of the things about chronic arthritis and some of these other autoimmune diseases is they do tend to have a slower onset. And, you know, it's really interesting with things that are not like a lightning bolt, the way we can kind of just get used to our children acting in these ways. So I would just say that if it's something that you're just now looking back and realize, like, this is such a common story and happens to so many parents where they say like, you know, all of a sudden we just realized we had to carry him for the first hour when he'd been walking for months, and then the swollen knee comes out, and then they realize, well, that was really weird, you know. And so you are definitely not alone if that's the case. And if it is the case where there's some ongoing morning stiffness lasting for much longer than 15 minutes, definitely something to bring up with the child's provider of how you could better optimize therapies so that, you know, even in remission, that kind of lingering symptom gets addressed.
Great, thanks, Laura. I'll pass over to Sammy. Oh, Helen, I think Helen's got a comment.
Yeah, I think it's, if I've made us add to Laura's comments, is that sometimes the presentations of arthritis are very subtle. As we heard from Yasir before, his little boy was 3 and falling over, and often parents may think that the swelling is due to an injury, perhaps, but it's the subtleties, and often it's looking back that parents will say, my child's not been right for quite some time, and often they'll say when they're better, they realize how bad they actually were for quite a long time. So, you know, for parents who are listening to this, or pediatricians or anybody else who's listening, or GPs who are listening in, if a child's not complaining of pain, don't be put off thinking that this might be arthritis, because the young child may not verbalize pain the way that you or I might, but it's often, you know, prone to falling, being a bit stiff in the mornings, being a bit, you know, upset in the mornings, difficult to get going. Subtle things is what parents can notice. So just beyond I think it's what we're trying to say is lower the level of suspicion. So lower the threshold to be concerned and the younger the child, the lower the suspicion. So sorry, lower the threshold for suspicion, I should say. So yeah.
Thanks, Helen. So in the chat, Abra Al-Mudahem has made a comment about my 3-year-old son has rheumatism and I'm very worried about him. So I wonder whether maybe if I can let Suleiman and also Yazir, as a parent of a quite recently diagnosed little boy, maybe you might like to start the discussion on how can we sort of support and offer some words of advice for somebody whose child might just be still in those very early days of diagnosis.
You want me to answer this question, or maybe Yasir?
Yeah. Well, whoever, you can choose between you. Yeah.
Okay, fine. I believe the new presentation, of course, it will be a bit tough for the family, but as Yasir said, the discussion with the treating physician will make things more easy, and with explanation, things will be more easy as well. So I would encourage the patients, parents to sit with the family, with their doctor, and to get all questions in their mind to be answered. Because this, I mean, the arthritis is something chronic, we need to get the answers. So it's not a matter of one visit to solve the issue. So we need it to be clear. And as Yasir said, it's a matter of collaboration between the parents and the physician. So things will go easy as they agreed upon the treatment plan.
Thank you. And Yazir, is there anything you'd like to add to that?
First of all, thank you for giving the opportunity, and thank you, Dr. Al-Mayouf. Indeed, Dr. Al-Mayouf, and I really would like to say that his unique styles in dealing with us as a parent was for me a game changer. The reason for that is that by natures, my wife and I are both educated. My wife, especially in the medical field, she's a clinical nutrition, so she read a lot. And the fact that when you read a lot and you are not an expert in the field, your fear also increased a lot. But Dr. Al-Mayouf, with his smart way, he absorbed all of these kind of things. And he put us into the stage. I remember the day when he told me, Yasir, we are here to treat, to target. There are some clear symptoms. Let's target it now. Don't wait. For me, it was really a rational thinking. It was something really to the point. Now, I know the side effects. We all read about it. Now, I really need my son to be good. I admit and understand that I could not cure him, because we believe as Muslims that cure 100% from God Almighty. So I said, okay, at least we'll do our best, because we were taught and learned that we have to do the cause. And the effect, we are not in control of the effects. The effects, the result is not in us. We only can do the job, the actions. So the actions was given by the consultations of Dr. Al-Mayouf, and I really in great debt for him. And alhamdulillah, we are now being for 1 year with treatment. Sorry for being long.
No, not at all. It's fantastic to hear your story. So the same dad actually has just added a tiny part at the end, which possibly maybe Angela, you might be able to, and Tede might be able to just say a little thing about. Will the disease continue with him, or can it stop? What do you say to a parent who asks you that question following on from a diagnosis? Maybe Angela, if you'd like to go next.
Yeah. So that concept of treat to target, I think, is really powerful. And for most of my patients, this is what I tell them. I say that, 1/3 of the children will start the medicines, they will improve, we will stop the medicine, and the symptoms just never come back. Then there's another 1/3, we will start the medicines, they improve, we reduce the medicines, and then the symptoms begin to rear their ugly head again. So, it keeps relapsing as you try and reduce. And then there's another 1/3 that you start the medicines, you give them the best, and they just don't improve. And I say that we still don't have the capacity to predict which third your child will fall into, but we are in the business of hope. And so we must do our best to get these children in the best condition that we possibly can, so that they can live their lives like any other normal child. So that's what I tell them. And by the time we're done, most of them take the risk to try the medications and see, and all the other interventions, physiotherapy, occupational therapy, to see how we can really improve the lives of these children.
Thank you, Angela. Teddy, would you like to go next?
So I would say that we use pretty much the same words as Angela. I would just like to add 2 things, and which is also kind of a reassuring for parents. With current treatments, more than 90% of children will have normal life without damage. So they will be able to live and lead normal life. And I also say to them that medicine is very rapidly developing. So 10 years ago, we didn't have certain medications. 20 years ago, we didn't have certain medications. And probably this will happen also in the future. So I tell them, if you ask me now, your child in 10 years, 20 years, probably we will be using completely other drugs that will probably even more targeted with less side effects. So our job at this stage is, with the currently best possible medications, we will treat your child, reach the inactive disease state so he will have no damage. And I don't know, maybe in 1 year, 5 years, or 10 years time, when we will have more targeted treatment, he will be able to be treated with even less side effects. But what we do say to our parents, that most of the children with these refractory courses of juvenile idiopathic arthritis do need constant medications, and they cannot stop their treatment. Thanks.
Thank you, Tede. Eve, do you have the next question?
So I'll
Yeah.
I'll jump in. Sorry, I've got next question. This is a question which I'll ask Laura to answer first of all. For your frontline clinical colleagues, a GP or a orthopedics department or A&E department, if they initially suspect that there's been an injury, how long should they leave it and keep treating it a suspected injury before they start considering it could be a paediatric rheumatological thing and refer on to a rheumatology department?
So this is sort of a tough thing to absolutely answer in absolutes, but I would say, you know, most of the GPs and orthopedics see a lot of traumas, acute injuries, and so anytime it's outside of that window of when you would expect it to be getting better, if your antennae are starting to go up, really refer earlier rather than later. I think I have, you know, when I see referrals and when I talk to people who are on the front line, I'm always happy to answer questions, to discuss, to engage. But, you know, I think that there's always opportunity for letting you know, like, oh, you know, this seems like a post-viral arthritis, keep them on some NSAIDs and we'll watch it a little longer, versus this is definitely something we want to see sooner. But I would say having that conversation, putting in that referral sooner rather than later is very important. And the more you do it, the more you will learn too of which way things went. And so that will be an iterative learning process. And, you know, I think for the patients where it will be juvenile arthritis or systemic lupus or some other autoimmune condition, we know for sure that earlier access to medicines and the right treatment and the right diagnosis prevents long-term damage. So getting in that window where it's in the beginning of the disease and we can really stamp out the inflammation and keep it out, can really change the trajectory of a child's disease course, and that is related to all sorts of other things that we can improve. And I think I heard that in Mr. Yasser's story about, you know, his conversation with his very smart and insightful physician who made that point. You know, we know what we're dealing with and we have the opportunity to treat it early and really make an improvement that could have an impact. The other thing that I was going to say earlier that's not kind of related to your question, but I just wanted to point out and kind of echo is what I really liked about Mr. Yasser's story was the way that he felt that he was a partner and was, you know, an informed and educated shared decision maker, and how empowered he seemed to feel by that and how engaged that made him feel. And I think that, you know, I really want to echo to any parents that might be watching that as physicians, we want you to be in that role. I don't expect any parent in this day and age where the internet is at our fingertips to not be looking up everything possible about their child's condition the second they hear wind of this diagnosis. But, you know, the internet is a wild place and there's no filters. And so what I say is it's fine to look, but let me be your filter. Bring your information to me. Ask me what are good resources, because you're going to look. It's human nature. I want you to look. I want you to be informed and educated. It will make all of this go better for all of us. But you need to have some direction on this journey, because there's a lot of stuff out there. So I love that part of his story. I love that, you know, that his physician saw him and his wife for who they were and really worked with them to address them as full teammates in this process. So
lovely, thank you very much. So refer early, and if in doubt, refer. Thank you. Aylin, did you want to say something to that?
I was just going to reiterate the early referral thing is super important. Well, as I've been told, I was only 18 months. I ended up in A&E at first, very similar to Yasser's son. I had a swollen knee. My parents thought it was just me being a clumsy child. But we got bounced around 6 or 7 doctors before someone went, she's mine. She's under rheumatology now. So I think early referral is super important. As well as that, before Helen was saying about subtleties, your child, especially if they've been diagnosed at a really young age, JIA will be their normal. you have to remember that while we hurt ourselves and we feel pain, if a child's grown up feeling the exact same pain, it's normal to them. So they may not be aware that there's something not quite right. So that's also something to bear in mind. I think quite an important point.
Thank you. Eve, did you have the next question?
Yep. So my question now is again from one of the pre-meeting ones. Has anyone had a trial giving both anti-TB, anti-TNF for a patient with uveitis, if you can't definitely exclude tuberculosis? Angela, I don't know if you want to reply to that one. So anti-TNF and anti-TB and uveitis.
So if every patient that I start on any disease-modifying anti-rheumatic drug, be it methotrexate or even etanercept, we screen for TB. And we must document that you checked and it was negative. In the event that you do find you've got a child with terrible uveitis, and unfortunately there's also TB in the background somewhere. So we've borrowed from the principles of how we manage HIV patients, where you would start anti-TB therapy and we'd give them for about 2 weeks. And you're monitoring to see how well they're tolerating, you're looking at their clinical response. And then when you felt that now it's okay to proceed on with maybe methotrexate, then you would go ahead. But the other thing that in my practice I've learned also is it's not just a matter of checking for the TB. I also sometimes just gauge compliance, because the last thing you want as a clinician is to have started somebody on etanercept, the biological therapies, and they don't come for their regular checks for blood counts, liver tests, kidney tests. Then it puts us in a very difficult situation. So we work hand in hand with the counseling team also, just to see how ready the family is to take up. But that's the approach that we would use in our setting in Kenya.
Thanks, Angela. Any other comments from the panel? Sammy, have you got a question?
Hi, yes. So this is a question I think which can be offered to every one of the panel members. And I think it might be nice. I'm just conscious of time now. We've got 9 minutes left. Time really does fly. I thought maybe we need to maybe try and end on a positive note, because you've talked a lot about how things are quite hopeful and that hope is so important. So I wondered whether is there one thing that each of the panel members could maybe mention that encourages them, that fills them with hope at the moment about either an emerging treatment or an interest in research, that's something that the patients and the families and then the clinicians listening to this might think of as a really encouraging and positive thing to sort of end this hour on. I don't know whether Helen, maybe you want to start, or?
Yes, thank you. I think it's really important that we do stress the positives. And I've been around a long time in rheumatology, and I can honestly say that when I started in rheumatology, it was quite common to see children who were quite disabled or in a wheelchair, or that is very rare now. It's very rare. So, an early diagnosis and access to the right treatment can prevent disability. Absolutely. And so, it's quite inspiring just to see the change in outcomes in the 25 years that I've been doing rheumatology. So it's stressing that the early diagnosis and getting on the right treatment as soon as possible makes a massive difference, and it's revolutionized the outcome for children with arthritis.
Thank you. Laura, would you like to go next?
Sure. I would say echo what Helen said, and then also maybe just because I work at the National Institutes of Health, which is a huge research organization. And I think earlier there was a talk about, we don't have the crystal ball and we don't know who's going to be on what path yet. But I think there's just tons and tons of amazing science going on right now, where we're trying, and a lot of collaborative research where people in our communities are starting to work together more and more around the world. And so we're trying to develop systems and and test so that we can at the beginning say, you know, more personalized medicine. You have this kind of genetic risk and this kind of response to medication. And so this is the right medicine to prevent damage in you. And I see that happening. It's coming little by little, but you know, it's building and building, and the ability to give the person the right medicine at the outset and prevent that damage, and the most targeted medicine so they get the best therapy with the least amount of side effects. I see all of that coming more and more rapidly every day. And I think that would be great for our patients and families.
Fabulous, thank you. Suleiman, you've raised your hand.
Yeah, I agree entirely with my colleagues. There is great advancement in the treatment in these days. And we agreed we don't have this chronic complication, disability in our kids anymore. So my message, we need to maintain good quality of life for those kids. They can attend their school, they can play with kids, they do their daily activities without any limitation. And thankful, the available medication help us a lot in this regard.
Thank you. So then Tede, Rebecca, and then Aileen. I think we'll go in that order. So Tede, you go first.
Thank you. So I would echo my other panelists, but I would just like to say that we now have medications that target different molecules within the immune system. So we already have a lot of medications that target at different sites. I think that the major step forward will be when we will be able to very early during the disease course recognize different subtypes of patients. And I think that in a foreseeable future, we will have this simple test that in a couple of days would give us this answer, what would be long-term prognosis and what would be, let's say, the most targeted treatment in these patients. The other aspect that I would say is important, that we are able to early recognize complications that are associated, not just with juvenile idiopathic arthritis, but also with other rheumatic diseases. And this also made a huge impact on a long-term prognosis of our patients. Thanks.
Thank you. Rebecca, would you like to go next?
Yeah, so it's great that we've got all these advances in medication, and I've seen firsthand the experience that I was over a year to diagnosis myself. My hip was damaged beyond anything anyone could do, so I've had to have it replaced. And the outlook I have for my daughter is so different to where I was at. And when people kind of feel sorry for her and they say, oh, she's got arthritis, I say, don't feel sorry for her. She has a very full life. She can run and jump and play, and she's just the same as her friends. But I think the message really to get home is that is dependent on having had a reasonably quick diagnosis. So it's all very well having all these amazing treatments, but if we're not getting those diagnoses through quickly enough, then all this hard work that's going on and all these amazing advances are not going to be as effective. So I kind of compare and contrast for people to give them hope. And also I think even in my situation 30 years ago, where there was no medication, there was no pain relief, there was nothing to stop the joint damage, I've gone on to have what I consider to be a good full life. Yes, my normal looks very different to perhaps someone else's normal, but I've done all the major milestones in life. I went to university, I got married, had children, had jobs, you know, all those major life milestones I've been able to do, even though my arthritis situation was not the best. So I kind of try to give hope to people to say nowadays things are much better for our children, but don't lose hope, because you know there's a lot that can be done anyways.
Thank you, that's really brilliant. So Aileen, and then just quickly Angela afterwards.
I was going to say I agree with literally everything that everyone has said. I think there is a lot of hope, and I think from my perspective as well, everything Rebecca said, I've got an ankle replacement too. I was one of those few that kind of fell off the cliff slightly, but I had really hard 3 or 4 years. But people often ask me, would I change it? I won't lie, part of me says yes, but I've learned so much from having arthritis. I've got involved with things like this I'd have never had the opportunity to do before. And even if your child or you yourself or your children's children ends up with arthritis, it's not the end of their life. And actually, with the treatments and the medication, it's not a massive brick wall anymore. It's more of a hurdle, and in some cases it'll be bigger, in some cases it'll be smaller. But you will learn a lot. Your kid will learn a lot. They'll be stronger for it. They'll have a greater understanding of the world, and often a greater appreciation for things than their peers might. Not something that I've sort of learned growing up. But every single person on this panel has said everything that I could ever think of saying so far.
Oh, thank you so much, Aileen. That's a really brilliant note to say. And Angela, would you just like to say your last comment, and then Eve is going to summarise the last hour.
I really agree with all the phenomenal comments by my esteemed panelists. And, you know, the science is so fascinating and so exciting, new discoveries almost every day, every year. But I think what is even for me more fascinating is really, we've always known this in medicine, but the paradigm shift where the patient is now the center, the focus. And, you know, to really applaud the organizers of this session, look at us, we're all the different 5 continents of the globe, and we've come together to share knowledge, to empower our patients and all our healthcare workers who might not be rheumatologists. I think that's really transformative. And you know, the future can only really get better. And of course, I'm biased because I'm a pediatric rheumatologist, but I know in rheumatology, we are really in the business of hope. So we soldier on, the struggle continues.
Thanks a lot, Angela. And I think, you know, over this past hour, we've really heard, it's been great sharing knowledge, hearing everyone's perspective and different take on all these issues that have been key to all the people who've asked questions today. So I'd like to really just thank everyone in the audience for joining us tonight. Thanks for on your Friday evening coming to join with us. Thanks to our panelists who've been fantastic and have shown real insight into the questions. And just to thank everyone who's been involved in events for Word Day today and continues to be involved into the evening, into the night, spreading the word and retweeting and spreading things on Facebook. We're all going to come back together in an hour. So there's going to be a new panel talking about how to live well with rheumatic diseases. Everyone's very welcome to join, and Richard's put in the chat the website that you can follow to register for. So hopefully we'll see some of you again in an hour, but I think the discussion will be very different. We've got a huge panel of allied healthcare professionals, charities, patients, parents, and it'd be great if you could all join us. So thank you very much, everyone.
Thank you. Good night.
Bye.
Good night.